Video. G'day, I'm Ted Jednak coming to you live from the sunny climes of Perth, Western Australia. Yes, we've flown west across this big brown land of ours and it's great to be here, catching up with friends and colleagues. We're counting down the days to the weekend because we'll be delivering our last sold out foot mobilisation therapies workshop here in Australia. It's going to be a gangbuster event with 33 dedicated practitioners who are physios, chiros, podiatrists, osteopaths. We even have overseas participants coming down. They've made a tremendous commitment to join us here this weekend. Can't wait to welcome them to Perth. And you know what? Half of the participants who are coming from the east coast of Australia. So I think there's going to be a bit of a tilt in the axis of the country when they all land here as well. It's going to be an intense weekend of drilling the skills so that we can all help more people like never before. Hey, welcome to today's Triple T TV show, Ted's Tips on Tuesday. In today's Triple T TV show, you'll discover how to see through the problems of using x-rays for diagnostic imaging. In fact, today's show is all about the tips and tricks to getting the best diagnostic images without you having to train as a radiologist or as a radiographer even. In fact, I have 4 key steps to better diagnostic x-ray images. So please stay tuned. This show will chew the fat on how to get that result happening much more often. You know, every time I do a workshop, I get asked about x-rays and how they're used for biomechanical evaluation, pre and post FMT treatment. Today's show, it's designed to answer the questions that you ask me and what you tell me about some of the incredible adventures. I'm going to let you know about the adventures that we've been on with our diagnostic imaging. And even one of our glorious registered guests who have joined us here, Tito Pinetti. Allora, buongiorno signor. He's no doubt going to be smiling along at some of the incredible opportunities, shall we say, that we've had in getting diagnostic imaging being part of our services. I've got plenty of tips for you. Some of them were good, some of them, in fact plenty of them not so good, and my tips for you are going to be how to avoid the hurdles and the mistakes that I've made in over the course of my career. We'll cover the 4 key elements of getting excellent diagnostic images so you can best serve your clients for even better clinical outcomes. I'll even jump into the topic of biomechanical x-ray assessments. This is a bit of a controversial field, but I'll let you know what happened kind of behind the scenes when I embarked on this path. You know, I even ended up being investigated by the Health Insurance Commission. That's our regulatory body here in Australia as far as x-ray imaging goes. It was a bit of a torrid time, but I'll let you know what happened and what to do and what not to do if you decide to go down this route, particularly if you want to avoid the onset of early grey hairs and sleepless nights, that is. Plus, we've got some other behind-the-curtain feedback from some MSK radiologists so that you can be confident that you're getting information from both sides of the fence, as it were. So if you're a podiatrist, a physio, chiro, osteo, remedial therapist, and you're interested in fixing feet, then welcome, you're in the right place. Thanks for joining me live from my new location here in Perth, Western Australia. Fantastic to be reaching out to the global community of foot fixers. Please say hi in the comments box below and let me know where you're from. In last week's Triple T TV show, it was all about neuromas and drawing on neuroma expert Dave Cashley from Scotland. The comments and discussions have been amazing. In particular, we had, let me check here, from Dave and Jeff Walton and Steve Wells and Marco Paul. Each of them raised some really interesting questions, some ideas, and even provided some updated reference materials for us to consider how we can all better help our clients with neuromas. And it's fair to say, while and I suppose our program went viral, we certainly went fungal. So there's a bit of an encouraging start. Hey, I was also here to, thrilled to hear from Judith from Austria. Sorry, that's in brackets. Because Judith, we met several years ago in Germany, a workshop I ran there, and she actually has a neuroma of her own. And she sent me this email. She said, "Dear Ted, I just wanted to tell you how grateful I am because of your willingness to share your deep insight and the way you communicate your knowledge. It just used your insight concerning the motor neuroma of my own foot. And then I taped it, and after one day, it feels better already. So thank you again, and I'm looking forward to see you and Lil in Göttingen." So all the best to you, Judith of Austria. So I don't know if that was an Austrian accent or what happened to my voice just then, but that was from Judith. So really thrilled to, looking forward to catching up with Judith again. Just a little bit of background with Judith. She highlighted personally for me how progressive the established countries like Austria and Germany really are. Now, some of you might have heard me refer to the amazing forward thinking of Germans, which we discovered personally when we landed in Frankfurt Airport. You see, in the airport, we were walking past these incredible facilities where parents who were experiencing difficulties with their children, they could resolve them literally in seconds, because what they had was baby change rooms. So if you had a baby and you weren't happy with it, you could just go in there, swap it over, pick another one, and try again. How incredibly progressive is that? Okay, anyway, so that's courtesy care of Judith. That's her story and experience of how progressive they are. Anyway. Last week's show on Morton's Neuromas had a fabulous freebie, and that's what Judith was referring to. And, there were some exercises and tips there that you can use for your clients, but Judith used on her own foot. So we had the clinical tests for neuromas, we had reference articles, as well as links to the pressure gauges that Dave Cashley referred to actually be able to measure forces and what a way to quantify what people experience with neuroma pain. So if you haven't already, make sure you get your free copy from last week's show. You know, during my 30-plus year career, I've had the privilege of learning from so many outstanding health practitioners from a diverse range of professions. What I'm going to talk about today is certainly no exception. I've tapped into some valuable diagnostic imaging gold from a couple of Australia's leading MSK radiologists. I'll talk more about them in a moment, but in today's show, it's all about the tips and tricks to getting the best X-ray images without you having to do all the training that a radiographer or radiologist does. In fact, there'll be 4 key steps to better diagnostic images. I'm just thinking, you know, when I went through my university training, I didn't get taught much about diagnostic imaging. I mean, it was pretty limited at best. I remember the technical issues of radiation generation, how ionizing radiation works, and you know, we got some images to show up pathologies like fractures or cancers or infections, but let me give you a little bit of background about how I got pretty involved with X-ray imaging. In fact, we even had our own in-house X-ray service at one stage, so yeah, I reckon I've learned a thing or two along the way. Okay, so it all started when my first mentor in foot mobilization, Harvey Lampel, he showed me some pre- and post-FMT X-rays. I had no idea what I was looking at, but he was convinced that the X-rays were showing clear biomechanical changes as a result of the FMT intervention. Then, fast forward 3 or 4 years, and I was working pretty closely with a chiropractor who was using X-rays as an important part of his initial assessments, and then he was doing follow-up X-rays to measure post-treatment changes. Now, I got to say, it was pretty impressive because even I, podiatrist, I could see changes in things like scoliosis angles. They were improving before and after. And anyway, over probably a wine or two, the chiropractor suggested that if I could work out a way to use x-rays as a pre and post FMT evaluation, then this objective measurement process could serve me in my pursuit of quantifying the effects of FMT. So that was, I suppose, a catalyst in pushing me along this path. This was back in the late 90s, and all of my inquiries about X-ray images and biomechanical analysis, they came to naught. So I decided to plough on ahead anyway. I'm not sure that I would advise a young me to do that now, but that's what I did back then. I had Gamble and Yale's text, Clinical Foot Röntgenology, and in that book there was a few examples where you'll see these angles and measurements of foot morphology. And we look at something like this one here, where we can see the arch profile and the calcaneal inclination angle and the medial beam here. So I had quite a few angles and reference points that I thought I could use before and after the FMT intervention. You see, a couple of things. When you've got an objective assessment method, and particularly when we're dealing with the human body, where there are so many variables that come along, and we as podiatrists particularly know the challenges we face with interventions like orthotic therapy and other type of musculoskeletal interventions. Sometimes it's very difficult to actually quantify the changes or the effects of our services and our treatments. So this, my rational or irrational thinking was literally about, can we use an objective measure like X-rays to validate what's actually going on? Sure, we might be doing gait analysis on a treadmill. We might be looking at in-shoe or out-shoe pressure sensor measurements, all in the quest to quantify what we're actually doing as our intervention. But there are pros and cons, and particularly when we're looking at X-rays and X-ray analysis. This is, I guess, one of the key considerations is that it's a static measurement in a specific moment in time. We are aware now that the dynamic evaluation of what happens with our clients, our patients, in their actual activity and when the pathological force is occurring, how do we measure and evaluate that? It's part of the conundrum that we have in the quest to quantify the actual services or the interventions that we're doing. The beauty of the X-ray analysis is that it does give us a very clear objective measurement in black and white, literally, of what's happening with the state of the joints, the texture of the joints, joint space, joint degeneration, and as well as we can look at some of the biomechanical relationships of the different joints to work out what's actually going on and where compensations may be occurring from. So that was also part of my thinking. And the other thing to be mindful of is that technology, heck, that impresses people. Now, I don't know if it makes that much difference to what we do or how we provide our services, but every time there's a new diagnostic tool or piece of equipment, there's usually a lot of people sort of jumping on board and seeing how can we make this work most effectively for our quest to get better clinical outcomes. So it was in 2002 when I was at the point where I made the decision that I'm going to set up a podiatry-based FMT specialised clinic where we could literally put all of the things that I'd learnt over the previous 6, 7, 8 years and focus specifically on a specialised foot mobilisation therapy service. Part of the service that we were going to provide is with our clients, if they were going to undertake the FMT treatment and the course of treatment, we would do pre-intervention X-rays, and we'd also do follow-up X-rays. And typically they would be at 3 months or 6 months or 12 months following treatment. So that was the genesis or part of what happened when we first set up the Foot and Leg Centre. We fortuitously had a radiology department, a radiology service about 500 metres down the road from us. So that was convenient. But one of the things I noticed was that the quality of images that were coming back for me to do the biomechanical X-ray analysis would vary depending on the radiographer that would be taking the images. So when we were comparing, what we were doing our best to try and compare apples with apples, so pre and post treatment, to try and make sure that what we were measuring was actually accurate to what was happening from a clinical perspective. So I then decided to literally go down to Benson's, which is the name of the radiology company, introduce myself. I met gosh, I can't remember what her role is. She was a manager. She oversaw all the radiographers and was kind of the liaison person. So Sue was very open in saying, great, let's get together, we'll have a bit of a chat. And what we chatted about was what I was trying to achieve and how Benson's could best serve our client base to get the results that we're after. It actually ended up leading to me training radiographers in taking the x-rays of the foot images that we needed so that there was consistency. They're a big organisation, they have, I don't know, probably a couple of dozen radiographers, and we actually ended up having 6 radiographers dedicated to us at the Foot and Leg Centre to take the x-rays and get all of the images taken care of. My younger sister is actually a radiographer, and I remember having a discussion with her saying, how come there's such variability? And she said, well, as a podiatrist, we call you a special request. So it's, yes, as podiatrists or people interested in feet, it's nice to be considered special, hopefully. Anyway, so the 4 key steps that we had to go through with the radiographers to get better quality images that were consistent so that we could be more accurate with our measurements of pre and post intervention. First one was actually setting up the client, the patient, in the correct stance position. You see, one of the problems that we were seeing was that the radiographers, they would have a plate, the plate that the clients would actually stand on, and normally what they would do is they put the plates so that both feet were on the one plate. Saved extra exposure and just more convenient for them. For us as podiatrists, particularly with biomechanical evaluations, what we need to do is have people standing in their relaxed stance position. But look, if you can do this right now, try this as a physical exercise. And that is, okay, just stand in your normal, comfortable stance position. So imagine a radiographer is telling you that. You turned up this radiology department and say, okay, just stand here in your normal stance position, your normal, comfortable position. What would you do? Well, you'd be thinking, oh, what is my normal comfortable position? And invariably people become self-conscious and they artificially start standing. Is this normal? I'm not sure about that. This was one of the dilemmas. How do we overcome that? So Becky, one of the great radiographers there, she had this great notion. She said, well, I just get my clients to stand there and I tell them to walk up and down on the spot for 4 or 5 steps and then just stop. And then that's their natural stance position. Nice trick. So we certainly employed that as a part of the process. Stand, walk up and down on the spot for a few steps, and then they adjust their X-ray image, the X-ray beam to take the image appropriately. Now, the actual angle of the X-ray beam is an important thing. Ideally, what that angle ought to be is as vertical as possible. So if we're doing DP view, I'm referring to, so with the DP view, the more vertical we can get that X-ray beam, the better. Now, part of the difficulty is that people have stomachs and upper body protrusions, so it means ideally we might have that X-ray, what we ended up with is getting that X-ray angle beam at 15 degrees. So if they can get that as standard as possible, that would be great. Depending on the actual X-ray equipment, sometimes the X-ray beam can be positioned easily, sometimes it has to be lowered or raised. There are all sorts of technical, logistical things that radiographers have to deal with, and that's dependent on the specific X-ray machine that they're working with as well. Because I remember at Benson's they ended up building platforms so that the clients could safely and stand up on platforms about 60 centimetres or 50 centimetres, I think half a metre off the floor. Because their machines couldn't, particularly for the lateral view, couldn't get right down to ground level. So there are all these kind of logistical things that we work through. The other key, the fourth key element is the radiation used, or the exposure. And when we're doing FMT, and particularly affecting the joints in the rear foot, the subtalar joint, the talofibular joints, the calcaneus and the midfoot, we need to get very clear the appropriate exposure levels happening in the rear foot area so that we can actually see the bones and the definitions of the bones. When radiographers take the x-rays of the feet, normally they adjust the exposure so they can see clearly through the forefoot. Problem is, the density of the forefoot is much less than the density of the rear foot. And so they do have filters and they can adjust it. It's a bit of palabra to get things sorted out. But if you're going to get the correct exposure, you need to be able to see the bones in the rear foot, particularly the talus. So that was another detail that we had to get consistent so that we get good quality images. I ended up then running an in-house survey. It was between 2004 and 2006. And what we did was all of the clients that met the criteria of the FMT treatment service, they would, part of their clinical evaluation, complete the foot health status questionnaire. So we had a way of quantifying their subjective foot pain levels, foot function levels and lifestyle factors. And then we went through and we had their x-rays taken as well. But here we also realised that we needed to be independent. So rather than me actually going through and ruling and measuring the x-rays, we want to remove that bias that could exist there. So part of the training of the radiographers at Benson's was for them to literally be doing all of the ruling and the measuring as well. So we went through a 6-week training program. Every Friday morning we had the coffees and the croissants there, and I would spend a couple of hours with them before their session started for the day. So this was an important element for us to be able to be getting these results and having them being independent of any bias from the practitioners involved. The key here is the relationship. You see, you think about every health professional, in fact most people, they want to do a good job. And Sue and the Benson's radiographers, they all wanted to do a good job as well. They just didn't know the details of what we needed specifically for them to do a good job. So establishing the relationship and setting up these trainings was all part of getting to the result of having good quality X-ray imaging. If you have a radiographer or a radiology department that you're happy with or not happy with, please hit a thumbs up or a sad face depending on your experience with your local radiology department. Before we're done today, I'm going to give you some important clues on how you can make sure that they're all definitely thumbs up happening for you. So show me what you got. All right. So I mentioned the Health Insurance Commission investigation. You see, I was requesting probably somewhere in the order of 50 to 60 images on a weekly basis of before and after X-ray for biomechanical X-ray analysis. The average podiatrist at the time would probably do about 10 or 12 requests per year. So clearly the scale of what I was requesting was far outside the typical podiatrist. So that's what raised the red flag with the Health Insurance Commission. There was quite an in-depth investigation. There was interviews. There were visits out to our clinic to see what we were actually doing. There was determination by the head authority in the ACT in Canberra, which is where the head of the Health Insurance Commission Department lies. But in particular was when the medical officer came to our clinic to see exactly what was going on, and we had quite a discussion about what we were doing and why we were doing. What happened was I literally had dozens of cases where I could show him before and after x-rays. And in particular, what he was most intrigued about was the way we could see literally the joint space, or where the cartilage is in joints, changing over the 3 and 6 month period of time. And this made good sense to me, because if we can improve the joint positions and we get the stimulation of synovial fluid and the chondroblast activity, the cartilage has a chance to restore itself, as long as it hasn't worn out to bone on bone. So if we've got some joint space there, we've got something to work with. And he, several times through, I remember this meeting, he was looking closely and he'd look right up at these x-rays and go, this kind of conflicts with what I understand as a medical doctor and what happens when joints wear out. It's typically a downhill or slippery slope, and they tend not to regenerate. So he was both surprised and, I have to say, probably reasonably impressed of how bodies can be helping themselves, and the fact that we had some objective evidence to show that and support that. So at the end of the day, the Health Insurance Commission concluded that what we were doing was absolutely valid and fine, and it was basically carry on, and so we did. But enough about my clinic. Let's talk about you and your clinic. When do you request x-ray images? Like, when do you find the need to ask for a diagnostic image? So if you just type in when and what those conditions are that you would request an x-ray image, I'll just make sure that I've got some good answers or some suggestions for you to help out with the quality of your requests. Okay, so we got suspected fracture. Okay, yes, very much so for as far as foot mobilisation goes. If there's any sign of a clinical sign of suspected fractures, we've got inflammation, some redness, we've got pain to touch, if we've got a clinical history of a trauma or an event that could be contributing to a fracture formation, that would be definitely, as Harvey, my wise mentor, said, is the last tip: never create a joint where there's not supposed to be a joint. And that's what would happen if you tried to mobilise or manipulate a fracture site. Good. All right, what else have we got? Okay, history of trauma, injury. Okay, not sure what's going on. So if you get to a point where you're thinking, I don't know what's going on, I better have a look inside, we're definitely going to talk about that in just a moment. Great, okay, thank you. All right, so I was chatting with a good friend and MSK radiologist here in Perth, Sam Cherian, and wow, did Sam surprise me with what he had to say about podiatrists requesting diagnostic images. First, a little bit of background that Sam shared with me. See, in the medical profession, this is how radiologists are described. They're like mushrooms. They just sit in the dark and get fed bullshit. I don't know if that's an official quote, but that's pretty much, you get the gist here. So the key message that Sam had for us practitioners was this: radiologists love to talk to referring practitioners. In fact, if you only do one thing as a result of today's show, it's talk with your radiologist. Like, call them, pick up the phone and speak with them. Now, I suppose the first thing is you've got to start a relationship with your radiologist, but a good radiologist will welcome your call and answer any questions that you have. But there is a caveat, and that is, if a radiologist knows what they're talking about, then they love to talk. But if a radiologist doesn't know about a certain topic, like feet or MSK radiology, they're usually probably pretty hesitant to talk. But, I mean, that's human nature, really, isn't it? If we know a topic, we'll tend to talk, and we'll talk a lot more about that than compared to something that we don't know about, or if there's a subject that we're not so confident with. But there are some keys, and that is, not all radiologists are the same. I mean, that's just like podiatrists or other therapists. Like, we're not all the same. We have different qualities, different strengths, different pluses and minuses. You see, to be a radiologist, you go through 5 years of specialising in radiology. And in that specialisation training, you cover all facets of radiology. And so, literally, it covers the whole gamut of conditions. And, you know, MSK radiology is only one small section, and MSK radiology of the foot and ankle, well, that is this tiny section as well. So the radiologists who do have good expertise with MSK radiology, and particularly with feet, have done even further training, and that's typically with an MSK fellowship. So the lesson you can take from this is find a radiologist who has done an MSK fellowship. Now, the way you're going to find that out is you're just going to have to make some calls or ring around or ask within your network. And if you don't have a network that includes radiographers or radiologists, then make the call and just let them know what you're looking for. But the key is then, once you find someone or several radiologists who do have MSK experience and expertise, is to talk to them. That is the absolute key. Now, when I say talk to them, are you not sure what you should ask for? Well, begin literally by, if you've got a patient, a client, a situation, pick up the phone and discuss it with the radiologist. So typically what happens is, and certainly speaking from personal experience, is if we have a condition, I don't know, maybe plantar heel pain, we think there's a heel spur that may or may not be connected with what's going on, we might organise for an x-ray. But then the patients are typically progress along a path which is essentially cost-based. And that is, well, if the x-ray doesn't show up anything, then they'll go for an ultrasound. If that doesn't show up anything, then they get referred for a CT scan. If that doesn't show anything, well, the MRI, because that is the gold standard, isn't it, of diagnostic imaging. But if you do something that flips all of that on its head, it would be this. If you've got a clinical presentation, and if you're not sure what it is, call the radiologist first, but make sure you have your list of clinical differentials. Because typically what the radiologist will ask you is, what do you think is going on? And you want to be able to answer that question. So if you can answer what you think is going on with the clinical presentation or the history, then the radiologist can make an informed suggestion saying, well, based on what you've told me, what I would recommend is, and it might be an ultrasound scan versus an x-ray image, or it might be they have the expertise and experience to be able to work out what to recommend, when, and what would be the most suitable. You see, radiologists' greatest frustration comes when, and I'll give you an example, is when a GP refers for, I don't know, even x-ray, and in the conditions or the clinical presentation section, they go, assess foot pain. That's it. That is a typical GP recommendation or referral request. Now, good news is that radiologists think that we podiatrists typically do a good job because we are specific in recommending what the site of pain is and what the condition may be. So typically, recommendations, because of our specificity, we might say medial forefoot pain or plantar heel pain, right foot. Now, when I heard that, I thought that was pretty obvious, but that's not what radiologists are typically presented with. So the thing that radiologists really want to hear is, what are the site of the symptoms? Because if they don't know that, they're really guessing or flying in the dark, literally, about how to work out what is going on. It means they have to then spend time and time and energies assessing over this whole gamut of possibilities rather than zeroing in on the condition or the problem that you're referring them for. So once they have that information, then they can work out the right test for the right condition. And this makes a radiologist's job much more productive, and it also enables them to provide a higher quality service. And literally it reduces their workload, which they're grateful for because it then means they can focus on the specific task to do a better job. Sam was telling me about a case study that literally came yesterday into his inbox. It was precipitated by a sonographer. So the sonographer is the person who does the ultrasound scan. And they don't report on the images, they just do the images for the radiologist to report on. So this patient got referred in for Morton's neuroma. Just think this, if money was no object, what would be the diagnostic imaging that you would request? You can type in your suggestion here. If cost didn't come into the equation at all, what do you think would be the most high quality, reliable, detailed diagnostic imaging form that you could request? Type that in for me. Yep, that's right. That's what everyone thinks, MRIs. So the magnetic resonance imaging is the gold standard. Yes? No, it depends. This is the key. So listen to this example that Sam told me yesterday. It was a young male patient who had just completed a marathon, but they presented with forefoot pain and a deviated second toe. So they were referred to the radiology department with suspicion of a Morton's neuroma. So the sonographer scans the affected area, confirms the mass that's there, and says, yes, it's a neuroma. Now, radiologist then gets those details and has to prepare the report. And if the radiologist doesn't consider it any further, then, sure, they would just sign off that that's what the condition was. So this particular case was the radiologist. She thought the presentation was unusual. In that so the marathon's just been run, the toe is deviated, then we've got a Morton's neuroma. That didn't quite match up from a clinical presentation. So she literally redid the ultrasound scan. Found there was a mass in the first intermetatarsal space. So it was an edematous build-up, and you know what? Was it due to a neuroma? No, it was actually a plantar plate tear. So then she rescanned, looking for the plantar plates, and found where the tear was and found the cause of this specific problem. You see, if she wasn't able to link in the clinical history and then do the appropriate diagnostic imaging, she probably would have signed off on a neuroma. And so this is why the clinical history details in your referral is a really important step. Now, whether you're going to write it out on the referral pad or actually pick up the phone and discuss with the radiologist, you need to get those details across. See, a discussion of the clinical signs, they're key to determining what the right diagnostic investigations will be. So here's your takeaway when ordering diagnostic images. Maybe here's your takeaway. I'm thinking maybe we could organise Uber images. I get distracted here. Anyway, so if you only get one thing from today's show, it's this sentence, and that is, I'm ordering this service, so whether it's X-ray, CT, or because I'm looking for blank, and that blank is the suspected condition. So in the example I just gave you there, look, I'm ordering this ultrasound because I suspect a Morton's neuroma. Better still, get on the phone, speak to the radiologist and saying, hey, I'm thinking I need to get some diagnostic imaging. This patient has just come back from doing a marathon, their toes deviated, I think it might be a Morton's neuroma. What do you think would be the best? Is it an ultrasound? Is it a CT scan? And have the conversation. And then through that conversation between you and the radiologist, you'll end up coming to the conclusion of what to request for the diagnostic imaging. You see, The other thing that you need to be mindful of is that those requests need the background information to help your radiologist provide the right service with the best diagnostic investigations for you. But what about if your patient has old films for a similar condition or an unrelated condition? I know I've had patients come in with a wider pile of x-rays and images and ultrasounds and bone scans, and they plonk them on the desk, and so you've got 10, 12 years maybe of history here. It's like, now, how is that going to help you? Well, you've got to take into account the clinical assessment of the condition or the complaint they're coming in right then at that time, and then work out, is this historical library of reference material actually going to serve us or not? I know from us at the foot mobilisation perspective is that if we're dealing with a condition that might be a history of 3 to 6 months, and they've got images that are 3 years old, it's probably not going to be that relevant. But if they've had x-ray images, for example, taken within the last 3 months, within this time frame, then maybe it is. The thing to remember is that diagnostic images are not all the same. They don't all investigate the same thing, and there is not one diagnostic image medium that will cover everything. You've got to, it's like horses for courses. You've got to work out what's going to be the best thing for the specific anatomical structure that you're looking at. You see, the clinical signs and the clinical differentials, they differ for infections, for tumours, for tendon tears, or tendon sheath injuries, or bone injuries. They all have different preferred diagnostic tests. Okay, so hopefully that's going to be of benefit to you when you go to make your next diagnostic imaging request. For those of you who've just joined us, had a terrific show today. We've gone through the 4 key steps to good quality x-ray images so that you can better serve your clients by getting more accurate diagnostic imaging. We've discussed the value of measuring body components objectively. We've talked about the importance of having a good relationship with your local radiology department and exactly how you go about doing that. We've covered the key actions that your radiographers need to do for high quality x-ray images that they don't typically understand. I've also referenced the radiology texts by Gamble and Yale. That's where these images came from. Also Chrisman's Foot and Ankle Radiology, excellent text as well. And these texts are really terrific for us foot fixers, and they help us do a more comprehensive job in assessing our clients. And I've shared some behind the curtain insights from one of Australia's leading MSK radiologists, and specifically on what they like and what they don't like about referring practitioners. Phew, what a show, jam-packed with practical good stuff. Hey, any questions? Type them in. I'll be happy to address those for you. Okay, what are we actually... okay, so when we look at these texts, the question is, what are we actually measuring? Well, I don't have the time to be able to go through each of these details in today's section, but certainly if you get hold of those texts, they have extensive chapters on what these angles, lines mean, and what specifically the purpose of measuring them is as well. So that is, if you want to go down that path, definitely grab hold of those texts. Chrisman had just a second edition published, would be literally in the last 12 months, so that's certainly updated. That's Chrisman's Foot and Ankle Radiology. Okay, how reliable are pre and post treatment assessments? Okay, so yes, the question of using x-rays for pre and post intervention. Look, when we're doing objective measurements with the body, comparing apples with apples is obviously very important. I'm not aware of any studies on foot x-rays that demonstrate reliability and validity of this. I know there are some studies on inanimate objects that compare before and after, and I've tried to take that material and apply it to the body, but the variations and variabilities of radiographers, X-ray equipment, and all those capers certainly have an impact on the actual reliability and validity of using those X-ray images for that function or that purpose. Cool, okay, so in next week's show, we'll be coming to you live from Margaret River here in Western Australia. It's the beautiful wine and degustation and surfing location of the West Coast. We'll actually even be going to a university down there too. Now, it is called Gin University, I think it is, so I'm not exactly sure how much there will be related to foot health and foot fixing community, but anyway, that's going to be, we'll share some insights with you next week, because what we'll be doing is we'll be highlighting the key learnings and aha moments from our sold-out FMT workshop that we're running this weekend at UWA, University of Western Australia. So if you aren't joining us here in Perth, you'll be in for a virtual CPD summary coming up in next week's show. You won't want to miss it, because those highlights are literally going to be generated by your colleagues who, just like you, are progressing their MSK assessment and treatment skills. So thanks very much for joining me today. If there are any questions or anything else that I can help you with, please don't hesitate to type them in. Let me know what you think of today's show. It's been huge with the whole radiology insights, so I'd love to hear your thoughts about it. Have you found it useful? Hey, if you haven't already liked this Facebook page, Foot Mobilisation Techniques, then please do so. Also, if you have a colleague who you know would love to get even better client outcomes for X-rays and other imaging, then please share this Facebook post with them. Make sure you join me next week on Tuesday's Triple T TV. And as my mate Matt Rimmer from the Gold Coast says, if you want to stay ahead, catch up with Ted. I don't think his voice sounds like that, but anyway, it's different from mine. Big thank you to Sam Cheran, who just was very generous and kind in sharing the radiologist's perspective of not just sitting in the dark, but providing what it's like on the other side of the fence to help me craft some of today's benefits to you. Also, big thanks to Dr. Lil for keeping me on track and crafting the most relevant materials for you as well. If you would like to thank Lil, please hit a heart and let that float along the screen. That would be lovely and greatly appreciated. Looking forward to showing you my tips again next week. You want a quick sneak peek? Oops, too much information there. Okay, it's been a blast chewing the fat with you today. I hope you've had a cracking good time. Until next week, same bat time and same bat channel, or same bat time here in Western Australia anyway. Until then, take your skills to the next level and see through more feet like never before. Cheers.